Okay, guys, let's do the next question. Let's see. You can pause any moment and read by yourself. This lady is gonna read for us. Let's see.
A 65-year-old man is brought to the hospital due to sudden onset shortness of breath. He could not lie flat due to breathing difficulty. There is no associated chest pain. 6 months ago, the patient was hospitalized with similar symptoms and responded well to diuretic therapy. Medical history is significant for hypertension, coronary artery disease, and transient ischemic attacks. The patient has undergone several percutaneous coronary interventions for stable angina in the past and had a right carotid endarterectomy 2 years ago. He has good adherence to his daily medication regimen but smokes a pack of cigarettes daily. Blood pressure is 210/100ths of a millimeter Hg, pulse is 104 per minute and regular, and respirations are 22 per minute. Oxygen saturation is 86% on room air. Examination shows distended neck veins and bilateral lung crackles. The abdomen is soft, obese, and non-tender. The extremities have no edema. Laboratory results are as follows. Complete blood count. Leukocytes 8,200 per millimeter. Total protein 6 grams per deciliter. Casts none. ECG shows cardiac troponin and I levels are not elevated. ECG shows sinus tachycardia with left ventricular LV hypertrophy. Echocardiogram reveals LV hypertrophy, preserved LV ejection fraction, and no regional wall motion abnormalities. The patient improves markedly with diuresis and antihypertensive therapy. Which of the following is the next best step in management?
So the options are this dexamethasone suppression test, kidney biopsy, plasma metanephrines, renal ultrasound with Doppler, serum parathyroid hormone level, and a urinary light change in assay. So which one you guys pick? So I will pick D. It's a relatively easy question. Definitely an easy question. Let's see what is the explanation.
A 65-year-old man is brought to the hospital. He could not lie flat due to breathing difficulty. Laboratory results are as follows. Total protein 6 grams per deciliter. Cardiac troponin and I levels are not elevated. 1. Resistant HTN, uncontrolled despite 3 drug regimen. 2. In association ARBs equals angiotensin.
This is an explanation.
This older patient with diffuse atherosclerosis coronary intervention, carotid intervention, has recurrent flash pulmonary edema, e.g. pulmonary crackles, distended neck veins, no lower extremity edema, despite a normal ejection fraction. In association with severe hypertension, this presentation suggests renal artery stenosis ROS. Renal ischemia, caused by limited blood supply to the post-stenotic kidney, induces the activation of the renin-angiotensin-aldosterone system, resulting in sodium in water retention, generalized vasoconstriction, and hypertension. Laboratory abnormalities reflect secondary hyperaldosteronism, i.e., hypokalemia, elevated serum bicarbonate. Unlike unilateral ROS, in which the unaffected kidney can typically compensate and the creatinine remains relatively normal, bilateral ROS can result in chronic kidney disease, CKD. Urinalysis is typically bland. The diagnosis is confirmed with renal imaging, e.g., renal ultrasound with Doppler, CT, Mr. angiography. Management includes blood pressure control, aggressive treatment of atherosclerotic disease, e.g., statins, smoking cessation, and ACE inhibitors with close monitoring of renal function, or revascularization. Choice A. The dexamethasone suppression test is used to identify Cushing syndrome, which can cause hypertension but is typically associated with abnormal glucose tolerance, striae, easy bruising, obesity, and an enlarged dorsal fat pad. Pulmonary edema is unexpected. Choice B. Kidney biopsy is indicated in a variety of diseases including many nephritic and nephrotic syndromes and unexplained acute renal failure. Although biopsy could be considered if further workup is unrevealing, this patient has bland urinary sediment suggesting against nephritic-nephrotic syndrome, and non-invasive diagnostic tests should be performed first. Choice C. Plasma magnephrenes are indicated to diagnose pheochromocytoma, which results in paroxysms of headache, tachycardia, sweating, and hypertension. Recurrent pulmonary edema is unexpected, and ROS is more likely in this elderly patient with diffuse atherosclerosis. Choice E. Patients with CKD are at risk for secondary hyperparathyroidism, and serum parathyroid hormone levels are routinely checked in patients with advanced disease. However, this patient does not have hypercalcemia or urinary crystals that would suggest that hypercalcemia is contributing to his renal failure. Choice F. A urine light chain assay tests for multiple myeloma, which causes CKD but is associated with hypercalcemia, bone pain, and anemia. In addition, a paraprotein gap, serum protein minus serum albumin greater than 4, is expected. Educational objective: severe hypertension and recurrent flash pulmonary edema in the setting of diffuse atherosclerosis suggests renal artery stenosis. Associated findings conclude chronic kidney disease and evidence of secondary hyperaldosteronism, hypokalemia, elevated serum bicarbonate. Urinalysis is typically bland. The diagnosis is confirmed with renal imaging, e.g., renal ultrasound with Doppler.
Thank you.